Mhm.
Good morning.
Good morning, Jessica. It's good to see you.
You too. Thanks to everyone who's watching and joining from afar. We're here to talk about the midwifery program and then also our collaboration with Swedish and the maternal fetal medicine group that we have here. We thought we would just start out by outlining our role and our working relationship. So my name is Jessica. I am one of the midwifery co-directors for Neighbor Care. Have been with Neighbor Care for almost 11 years now, and we've had a long working relationship. At Neighbor Care, we have midwives at 5 different clinical sites. Just in terms of the impact, last year we attended about 470 births, so 470 new Neighbor Care babies, generated over 7,000 encounters, and cared for over 1,800 people. As midwives, we get to care for people in pregnancy, postpartum, at the hospital. We get to care for their newborns as well. And then we also get to care for people outside of pregnancy for their reproductive health care. And we have the honor in pregnancy of getting to work with your team as a healthcare home for the people that we care for. We get to care for a lot of individuals who might otherwise not get midwifery care. And so we have a population that tends to be more high risk than a lot of midwifery groups. And that leads us to have a really great working relationship with your team, because if somebody's pregnancy is more complicated and we need specialty care for them, we get to refer them to you all to sometimes co-manage or consult on their pregnancy care. I'll turn it over to you, Dr. Sorensen, to introduce yourself.
Right. So Tanya Sorensen, I am a maternal fetal medicine physician. I always say that first. And I'm also the executive medical director for Women and Children's for Swedish and the North Division of Providence. And I also lead at the Providence level. I have been at Swedish for 30 years, and I've really valued my relationship with Neighbor Care. As you say, your patients tend to be higher risk patients, and yet their social needs and the cultural needs are as important often as their medical needs are. And so having that ability for the midwives to care for those patients is, I think, paramount to the success. And you do have great success rates with your outcomes. And so I try to remember to always congratulate you on that, because it's very hard work.
Thank you.
So yeah.
Thanks. Yeah, speaking of the people that we get to care for, just a little bit more about the folks that we care for at Neighbor Care. About 48% of the pregnant people that we care for identify as either Black, African, or African American, and that's actually higher than Neighbor Care as a whole. In addition to that, about 45% of the people that we care for are best served in a language other than English. So a lot of complexities in terms of the needs of the folks. So talking more about that, what do you feel like are inequities in care that we're aware of and work together to address?
Yeah, I think that is one of the really valuable things about Neighbor Care. The population you're serving is a population that is at huge risk, just statistically, of having poor outcomes, both maternal and infant outcomes. And in the United States and here, we have worse outcomes for Black patients pretty much across the board. And that is related to a long history of systemic racism and bias. And I think it plays into a lot of what's going on. We have been trying really hard to reduce those disparities. And I think that having practitioners such as yourself is really one of the things that we are using to help us in that area. A big initiative right now at Swedish is to try to decrease the discrepancy in C-section rates between Black and white women. Black women have a much higher risk for C-section, and it's a very measurable outcome. So that is something that if you had a C-section or you didn't have a C-section. So it's something that's pretty easy to measure. And so that is what our focus is. And I know just from what I know that your C-section rates are actually quite good, and especially considering your population. You want to talk about that a little bit?
Yeah, I'd be happy to talk about that. Yes, we are really proud of the outcomes that we're able to achieve. Like we were just talking about, given that we care for a population that at a national and even on a more local level have really disparate outcomes. Here at Neighbor Care with our midwifery teams, we're able to achieve outcomes that surpass what Swedish is doing at a hospital level, what Washington State is, what's happening in the state, and also the country at large. One number that we're really proud of is the number of people who are able to have vaginal births after C-section. With our group, 75% last year achieved, or sorry, 2 years ago, achieved a vaginal birth after cesarean, which is much higher than the national average. And then in terms of our C-section rate overall, it ranges anywhere from 22 to 26%, which compares to like Swedish and national averages that are over 30%. And for people having their first baby, our rates run around 20 to 23% as well, which is also lower than hospital and national averages that range from like 25 to 27%.
Yeah.
Things that we're really proud of.
And that matters. We focus on C-section rate, and people sometimes ask why, right?
Mm-hmm.
But it really is an important distinction. If somebody needs a C-section, truly, it can be life-saving. If they don't need a C-section and they end up with a C-section, it can delay bonding between mother and baby. It can increase bleeding, it can increase infection, it can increase time off from work, it can increase the risk in future pregnancies. So there are a lot of reasons to not have that first C-section unless it really is necessary.
Yeah.
What do you think is the secret to your success there?
Yeah, that is a great question. And it's something that we as a group have been working to help sort of explain the why. So for the last number of years, we have been working with DNP students, which are Doctor of Nursing Practice students from the University of Washington. And I think we are now, I want to say, in at least our 4th year of working with those students. And each year we've been building the model for what it is that the Neighbor Care midwives do. So it started with interviews with the midwives, really trying to figure out what do they think are the things that contribute to this model, talking to patients, talking to our partners at your office, and as well as our Kaiser consultants that we work with as well, and really trying to tease apart what are those things. And I don't think it is any one thing in particular. I think it is the program as a whole. So it is the commitment to equity that comes from the midwives. It is the high touch and just midwifery model of care in general. It is the support that we provide for our pregnant people with our clinic, and importantly, our perinatal coordinators who are addressing the social determinants of health on a daily basis by helping people with things that might be easy for others, like maybe getting a breast pump or maybe getting their car seat or making sure they sign up for Washington paid family leave, and really providing a very hands-on approach to make sure that people get the services that they need. So they have a breast pump so that they can continue to pump when they go back to work, so that they can get paid for their time off, or even just to get to an appointment. One thing that our coordinators do is they schedule folks for their ultrasounds, they schedule them for their appointments at your office, and then they schedule them a taxi to make sure that they get there. And I think that makes a huge difference just in terms of how we were able to provide such robust support and ensure that folks get the care they need so that we can achieve some of these amazing outcomes.
Yeah, I completely agree. And while you're talking about that, as we evolved and really started focusing on birth equity, we used a lot of those tactics. We've implemented those, and, things that you've been doing a while and are really pretty evidence-based. So we have a doula program, which I'm super proud of. It's hospital-based, and a few years ago, Saleha Akambe started our Black Birth Equity Initiative, which, Empowerment Initiative. And it basically paired Black patients with Black doulas. And that then evolved into what we call the Just Birth Network, which includes that program and also health navigators and community partnerships, including with Neighbor Care. When you listen to patients and you put them at the center of their care, and you kind of drop the paternalistic attitude, and you provide that labor support, you can not only decrease C-section rates, you can make patients much happier. And in my estimation, the trust in the healthcare system is something that's really suffering. There was actually an editorial in the New York Times this morning about that. I don't know if you saw it. It's very interesting, and it's very true.
Yeah.
So that building of trust is sort of paramount, and we've lost the trust. And so that is something that from all different all different avenues we need to regain. And that listening and considering their culture and not imposing our culture is key to that. And I think you do that really, really well.
Yeah. And I think the Just Birth Network and the Swedish doula program has been so instrumental in helping to achieve those things. I was just thinking about one of our cultural navigators who's Amharic speaking, and she, I got to work really closely with her caring for somebody who was experiencing some complications after her birth, and felt like in her birth, she wasn't listened to in the way that she wanted, needed to be. And that person was so key for us really being able to understand what she had gone through, and also to really escalate at a Swedish systems level where it felt like things had gone wrong for this individual. And then also in terms of trust and the experience, I was just thinking about our partnership as well. And I think that is really, really key. I was thinking about another person who was carrying a baby who was known to have cardiac anomalies, and was going to require a lot of complex care management at the time the baby was born, because the baby was going to need surgery right away. And this was somebody who should have probably transferred to your service completely, but wasn't interested in doing that because she wanted to stay at her healthcare home. And our teams were able to work together to ensure that she got her prenatal care. She had a plan in place with all of the neonatal teams that were needed after the baby was born as well. And so just that collaboration we were able to provide an experience that met everybody's needs and made this family feel well cared for.
And I think that is key. And you're right. A lot of times patients do end up transferring out of midwifery care because they quote risk out. And as mentioned before, your patients are high risk. And I do think that the outcomes are improved by having you continuing to be involved. I have never known anyone in your group to overstep. They always know when to ask for help, and they always know when they're beyond their scope, and we trust you. So it makes it much easier to work with you. I just want to call out, we're two white ladies sitting here talking about birth equity.
Yeah.
Thoughts about that and how do we reconcile that?
Yeah. I think it's really acutely important. I'm so glad that you brought that up. And it's something that we as a group, and I think Swedish at large, is really working to address, and midwifery at large as well. I think that Black midwives number only about 4% of our workforce, whereas like we were talking about at Neighbor Care specifically, 48% of the people that we care for identify as Black or African American. So at Neighbor Care, and within our group, it is something something that we are working to build towards over time. So specifically at Neighbor Care, what we were doing is we've created a pipeline of mentorship. We talked earlier about our full team, and so we have perinatal coordinators who are providing care coordination. We have OB nurses as well. And so we have gotten to have the privilege of seeing multiple people now who have moved from a perinatal coordinator role into an OB nurse role, into nurse midwifery school. And now some of them have even gone on to join the midwifery workforce. And in that, it is our hope. Our group has a very, very slow turnover rate because we all love what we do and are very passionate about it and stay for years and decades. So our goal is to kind of replace ourselves over time with this pipeline that we have created. And it's very, very important to us. And I see it happening at Swedish as well.
Yeah, I would agree with that. One thing that is important to us on our side is we have a new OBGYN residency. Our second year class is just finishing their second year, and we've recruited a third year class. There'll be 4 classes altogether. And we have a partnership with Meharry Medical College, which is a historically Black medical school. And we have one of our first class came from there, a Black woman, and now one of our upcoming, our third class is another Black woman from Meharry. And in Washington State, just as you say, the number of Black OBGYNs is pretty close to the same as midwives in terms of percentages. So I do think that's really important. And I do also appreciate that the doulas, the Black doulas, help us bridge that gap and are really strong advocates for the patients.
Yeah, we definitely rely on all of our experts that we have around us and providing the care to really meet families' needs while recognizing our role and limitations as white care providers, for sure.
Yes.
Yeah.
And we always have to recognize that. Advocacy.
Yeah.
Do you want to talk about that, or do you want me to talk about that?
I'll let you talk about it.
Okay.
Yeah.
All right. So there's a lot of advocacy going on, and I have to credit Providence for being deeply involved in that work. In 2025, CMS will start paying, Medicaid will start paying for doulas, which has never happened before, which is so exciting. And the Just Birth Network was visited by the Biden administration's team. And a lot of the elements that we have are incorporated now into the omnibus bill that's going into effect. So I think that there are some good things happening, and I think that we have a long way to go.
Yeah.
And I think that one of the things that we both can do, and I think try to do, is encourage the patients to advocate for themselves and and having doulas to advocate for them. Because if you're not comfortable with what's going on and you can't speak up, you're not going to have a good experience. Having as we like to say, having a healthy mom and a healthy baby go home is not enough. They also have to have a good experience. So they'll come back and they trust us, and they will seek care when they need it. And I don't think we've done a great job of that to date.
Yeah. It is one thing that I feel like at Neighbor Care, we really strive to do. And one of the things that is most gratifying for me personally, working in a community health setting, is that we get to see families over time and have them come back for birth after birth, and even generation after generation. For those partners who have been in the group more like 20, 30 years, they have gotten to see people come in with their daughters, who they delivered, and then go on to, so I do feel really proud that I think we are able to achieve, for the people that we care for, a sense of being heard and seen. And I think that is a big piece of the puzzle that we were talking about before, in terms of why our outcomes are the way that they are. And thinking about the future, it's why we're building this model, because we want to be able to show like, what is this and how can we replicate it across the country where the outcomes are not what we are seeing within our clinic at Neighbor Care. And it's why we need funding for our programs, and really appreciate all of our listeners tuning in today. Yeah.
Yes, yes, agree. This is absolutely a role model. And yeah, a lot of communities don't have the advantage of having neighbor care midwives. One of the things that I actually really appreciate is your geographic kind of, because you have several locations and midwives are seeing patients at each site, the geographic coverage is really good.
Yeah.
And so you do end up being able to serve a variety of patients from really around the region.
Yeah.
And that's another part of the model that I think has been very successful.
Yeah, we appreciate that. And folks are still coming to see us even when they move slightly out of our geographic areas. We are seeing that people are coming from, further south, further north to still stay with us. It's a real joy to get to continue to care for people.
Well, you want to increase the number of midwives, you don't have turnover, let's increase the number of births.
Yeah. For sure. Keep sending people our way.
Yes, okay. All right, sounds good. Anything else? Do you have thoughts for our future together?
That is a great question. I think just always continuing as a group, we are always trying to widen the circle of the number of people that we can care for. So we really appreciate the collaboration and support. We are always trying to push kind of and maximize the circle of people that we can care for with initiatives like in this year, we're trying to bring insulin management directly to the people that we care for so that we can keep people in their healthcare home. So I just look forward to continuing that partnership of being able to have your team support us so that we can maximize the people who can stay in their healthcare home.
Sounds like a plan to me.
Yeah. Thanks. Well, we really appreciate everyone here today. We appreciate people's time and also people's financial support of our program so that we can continue to do this work. I do think we have a few minutes if there are any questions in the chat or from our neighbor care facilitators that we have here. You can get in this work. Oh, great. Yeah, so the question that we have is if you are a student and you're interested in pursuing this work, where would you start? Do you want me to take that?
Yeah.
Okay, great. Yeah. So one way is just that pipeline that I was talking about has been a really amazing experience that we've been able to guide people through. So starting with becoming a coordinator, or another pathway into birth work is becoming a doula also.
Yes.
Is another wonderful avenue. We see many midwives who go that route as well. And yeah, to become a nurse midwife specifically, you train as a nurse first and then continue on in graduate school to get your doctor of nursing practice as a midwife. But there's definitely many avenues and many entry points. And we love getting to work with the community and finding those people who we can mentor into roles and clinical pathways as well.
And Jessica, is there not a program both at Seattle U and UW that goes, if you want to be a midwife, that you can go nursing into midwifery directly?
Yes, that is true. And that's actually the avenue that I took as well. I didn't work as a nurse before I came.
So did my daughter.
Yeah. Before
she was a patient care coordinator too.
Yes. So for folks who know that a midwife is what they want to be, there's accelerated nursing programs that instead of a longer bachelor's program or a 2-year community college program to become a nurse, it's more like a 5-quarter, 15-month accelerated program of nursing. And then depending on the school, like a 2 to 3 year, mostly now doctoral level, but some master's level to become a nurse midwife.
Yeah.
Okay,
All right.
wonderful. Thank you everyone for joining us. Thank you for Neighbor Care support. And we look forward to continuing this conversation offline.